Good morning, dear students. Today's interesting topic is about one section in hematology. Hematology deals with blood. So, what are those things which we have to look for? In this setting, what I would like to tell at outset itself is that we shouldn't try to emulate or mimic the specialties of pathology or a hematologist, because they are subspecialties. In their own domain, they are experts. But as an MBBS graduate or thereafter when you are practicing, daily almost you come across many reports, especially with advent of laboratories which are proliferating every nook and corner of our country, and with automated assays, with dire competition, we will come across a booklet of investigations which contain right from unknown things to many things which sometimes take you by surprise. Especially among these relevant is related to CBP, that is complete blood picture, also known as hemogram. Though these terms are used interchangeably, but there is slight difference between these two. In some laboratories, they give ESR along with this CBP and then they dub it as hemogram. But in some laboratories, ESR also clubbed under the heading of CBP. But we are not bothered about those economic logistics. Here, as a clinician, what we have to do when a patient brings some reports, especially relevant to hematology. So, most important one is whatever parameters that instrument gives, like RBC, WBC, platelets, kind of those things. Okay, so far well and good. There is one denominator in that hematology report labeled as peripheral smear. By the time when we reach that, we will be exhausted by seeing all these elements whichever sometimes surprising to us. For example, there is an index known as Mentzer index, which is actually not much useful, but I am going to just tell because most of the laboratories report that parameter. So, down the thing at footnote, at the report of hemogram, you notice one small thing, but it is one of the most important things, actually has to be assessed by a pathologist, to be reviewed again sometimes if there is a discrepancy, because recently we have seen an online laboratory which so-called dubbed itself as a low-cost laboratory has generated numerous reports of peripheral smear labeling every person who attended their lab for investigations having myelocytic cancer. We were taken by surprise. First 1 or 2 patients, it's okay. But those patients who are bringing reports from that laboratory with the peripheral smear itself showing some type of hematological malignancy, we have to be doubly careful. So, in that setting, as a clinician, means at either MBBS level or at MD level or at further thereupon, because no specialty is excluded from analyzing the reports of hemogram, one should be well vigilant and also means little bit have knowledge about interpretation of peripheral smear. So, today's section is about how to interpret peripheral smear as a non-specialist. Okay, this is not exhaustive lecture about peripheral smear that is usually done on grand rounds of hematology or pathology. Okay, usually there is an order in interpreting peripheral smear. Most of the times, pathologists do look for smallest cells possible. So, what are those small cells among all these blood elements we know? What are they? Platelets, RBCs, WBCs, some abnormal cells, kind of those things. Among all these lineages, smallest ones are platelets. They are hardly 1 to 2 microns in size. 1 to 2 microns. Remember, I am using this word size, not shape. Okay. Actually, we have to start from the thin smear, means feather end of this smear, and start examining for platelets. So, whenever a peripheral smear is prepared, always look for smallest cells, platelets. And actually in clinical practice, it is going to be much more useful rather than looking for RBCs. Okay? Because platelets are so small, they are viewed under this technique, magnified 100 times, oil immersion technique. and in minimum fields the pathologist has to examine are from 5 to 6 fields and multiply by 20,000 to get overall picture of platelet count. Usually for every 20 RBCs, one platelet is present. Platelets are irregular in shape, but here shape is not going to matter. What matters is their size. Any platelet which is large in size can be suggestive of systemic inflammation or inefficient marrow production and of those things, because by the time platelets are released they are fragmented and small in size, but in ineffective production what will happen, marrow tries to release means expeditiously immature platelets means megakaryocytes. So if you are seeing megakaryocytes, you have to suspect some problem with marrow production, myelofibrosis or myelodysplastic syndromes, or another thing myelophthisis. There are various terms for various things, but umbrella word for is that inefficient marrow production. Okay. Second thing what you are going to see most often on peripheral smear is platelet clumping, either because of artifact or because of reaction to anticoagulant. Most of times we put this hemogram sample EDTA, sometimes EDTA can lead to clumping of platelets. So in some settings either we have to use citrate, alternative one, or heparin, and sometimes we have to adjust this platelet count for their volume also if it is quite large. Okay. So megakaryocytes, and second one what we notice with the platelets examination is clumping. This clumping sometimes can lead to spuriously low platelet count, especially in the setting of fever. So whenever you are seeing a patient fever, when you suspect dengue kind of those things, if you are seeing low platelet count, look for clumping on peripheral smear. Another one which I would like to tell is pseudo-thrombocytosis. Any platelet count less than 1.5 lakhs is known as thrombocytopenia, that you all know. Thrombocytopenia is less than 1.5 lakhs. Thrombocytosis on other hand means excessive production, means you can say more than 4.5 lakhs. It is thrombocytosis. Sometimes what happens is during the preparation of smears, WBC may lyse, producing various fragments without anything, and they mimic platelets. So fragmented WBC have to be excluded in the diagnosis of thrombocytosis. Here factually platelet counts are not elevated because of artifacts due to damage to WBC membrane, especially polymorphonuclear leukocytes. It can lead to spurious elevation of platelet count. Now this is the one, thrombocytosis, where we come across dreaded one is again bone marrow related malignancies. It's okay. But in states of chronic inflammation also, especially in iron deficiency anemia, you can see elevation of platelets. Why it happens? There are many mechanisms postulated, but among them is most one often told during grand rounds is homology between what is that hormone which stimulates erythropoiesis? Erythropoietin. EP. The hormone that stimulates platelet production is thrombopoietin. There is especially around 35 to 50% homology between these two hormones, especially at N-terminal end. So what will happen in iron deficiency anemia? Low iron stores. So bone marrow will be triggered by erythropoietin. Erythropoietin comes from the majority, 99.9% comes from the kidneys, or hardly 0.1% comes from the liver. This erythropoietin stimulates marrow production. So there might be overlap of, means spillover of erythropoietin effect on the thrombopoietin receptors. This is the one mechanism attributed. Second one is, because iron deficiency is this iron deficiency or iron block can lead to decreased RBC count, simultaneously removes the block on platelet production. So this is second mechanism that has been proposed, but remember, none has been proved in reality. These are all mechanisms. Third one is, there is common stem cell precursor for both RBCs and platelets, especially at megakaryocyte stage. Common progenitor. At that progenitor stage, erythropoietin can lead to increased platelet production, because iron deficiency is blocking erythroid production, means erythroid proliferation. So these are the mechanisms that have been attributed. So whenever you see excessive platelet counts, you need not worry about bone marrow pathology. Do iron studies to assess for iron deficiency, especially don't miss ferritin levels. If iron deficiency is there, at the end of second or third month, this thrombocytosis picture will become normal. On other hand, in spite of a normal iron profile, if the patient is having high platelet counts, especially more than 45 to 50 years of age, search for bone marrow diseases. Okay, got the point? So in the setting of a young female with full-blown anemic features but thrombocytosis, you need not worry about myeloproliferative diseases. Rather than look for iron deficiency anyway, especially in countries like us, treat. If it is not subsiding, then you can assess, especially in those patients older than 40 years of age. We will go to next slide. So depending upon the size we are progressing, what comes next is RBC. From the outset of MBBS, we know, especially from physiology days, RBC is a biconcave disc. God has created like this so that its surface area becomes maximum. While examining under microscope light, because of this concavity, this central area appears little bit pale. So there will be central pallor, and moreover it is biconcave. Most of the hemoglobin is at their extremes, like a dumbbell here. Here hemoglobin will be little bit lesser. So this central area of pallor is a normal finding. If you see a biconcave disc with a central pallor, most of the times it is normal RBC. The size of RBC is the nucleus of small, not large, small lymphocyte. That's why when pathologists are giving reports of microcytic or hypochromic picture on peripheral smear, okay, automated labs can measure directly. if the size of RBCs is similar to a nucleus of small lymphocytes, it's okay. On other hand, if the size is small, it is microcytic, microcytic RBC. On other hand, size is larger than nucleus, it is known as macrocyte. Most common cause of microcytic because of ineffective erythropoiesis is iron deficiency, and macrocytes, especially when there is a large cytoplasm, this is because of other nutrition deficiencies which are related to nucleic acid synthesis like B12, folate deficiencies. Also, you come across few terms on peripheral smear which are known as anisocytosis or poikilocytosis. N-iso, not of same size, N-iso, yes, like this you can remember. So, anything varying in size, it is known as anisocytosis. On the other hand, anything variation in shape, poikilo means assuming various forms, poikilo means poikilothermia means varying temperatures, it is not a size, it is varying shapes, it is known as poikilocytes. So, anisocytosis, poikilocytosis are because of inefficient RBC production, most often seen in our setting is in again same iron deficiency. Okay. Second one is, as this autoanalyzer is assessing MCV directly, sometimes it can be normal in spite of presence of iron deficiency. What I told earlier, in the setting of iron deficiency, there will be decrease in the size. But on other hand, if the patient has got nutrition deficiency so much that in vegans along with B12 and folate deficiencies are there, MCV can be normal. Sometimes MCV can vary also, means some cells will be smaller in size, some cells will be larger in size, so it can produce various forms like dimorphic anemia. Dimorphic picture also may result. What I am going to stress is that MCV, if it is normal, it doesn't mean that patient has got nutrition deficiency. On the other hand, MCV shows abnormalities, then definitely it shows there are abnormalities as far as its constituents are concerned, means their synthesis, kind of those things. So, insert settings, one parameter that pathologists often employ, a formula based upon the MCV. Because there are various forms of RBCs in their size, so they assess their distribution with standard deviation. They may take to 95th percentile or even to be accurate 98th percentile and take the mean of this MCV and divide these things and multiply by 100. So, it gives in a percentage form. The normal percentage of red cell distribution width is up to 15%. Got the point? If any RBCs in various forms, means standard deviation, some are small size, some are big size, some are usually a normal size. If there are too many, so the distribution will become larger and larger. Hope you are clear about this point. Why, you may ask, why we have to calculate red cell distribution width when MCV is normal? I told earlier, size varies, but volume is 3-dimensional. So, in the setting of both iron and B12 deficiencies, for example, MCV can be normal. V means volume. Remember, there is a difference between volume and size what we are estimating. So, it can lead to anisocytosis, means variation in size. So, MCV can be normal. Insert settings, you have to look for red cell distribution width. Because in thalassemia, there won't be any break on the erythropoiesis. Cells are uniformly normal in size, not volume. So, distribution width doesn't exceed more than 15%. On the other hand, in iron deficiency, because of ineffective erythropoiesis, there will be variations in the size. Some cells getting good iron, some cells not getting enough of iron. So RDW exceeds more than 15% in iron deficiency. So in such settings, red cell distribution width differentiate between iron deficiency anemia and thalassemia. Another setting where red cell distribution width usually helps us is in assessing dimorphic anemia, which already I have touched upon, where both B12 or folate and iron deficiencies are present. There are various forms. For example, a patient is having autoimmune gastritis, which can lead to both B12 and iron deficiency. So in such settings, even if MCV is normal, because of compensatory changes of both iron and B12, distribution width will be increased because there will be change in the size. So red cell distribution width varies from small cells, normal size cells and big cells. So in dimorphic anemia, red cell distribution width means more than 15%. It is there, that is seen in dimorphic picture. Got the point? I think this slide should be clear to you. If still there is any doubt lingering on part of you, you can either contact me or you can ping me at YouTube. Okay, let's move on to next slide. In some laboratory reports, we come across this person's name, that is known as Mentzer index. He published this way back in 1973 in Lancet journal. Lancet journal has been famous for good quality of publications, but of late, I don't know, it has become more of political rather than scientific. It's okay. Let us discuss this Mentzer index. It is nothing but, again, numerator is MCV, mean corpuscular volume divided by total red blood cell count, RCC. So the lab automatically gives this result. If it is less than 13, same basic principle. There is no ineffective erythropoiesis in thalassemia. That's why cells are of same size. There won't be much variation in the volume. It will be less than 13. On the other hand, because of anisocytosis, if it is 13 or more than that, it is more suggestive of iron deficiency anemia. In those days where electrophoresis was not available, this used to be one of the tests that used to tell about which condition it might be. Not a definitive diagnostics, it might be. So from historical perspective and also for whenever you are coming across that report, you shouldn't get surprised. So Mentzer index is nothing but an, you can say, old variant of red cell distribution width. Okay, got the point? We will move on to next slide. This is about what are those things that might be seen on peripheral smear, especially as far as morphology of RBCs is concerned. Most of them are blue, which granulations or stains seen in the cytoplasm of RBCs. Remember, it is not exhaustive hematology, but they are suggestive of premature release of whatever nuclei and their contents into the circulation. So immature forms might be seen on peripheral smear examination. So most of the times the nuclei contains RNA or their materials and their nuclei, and especially when these RNA associated ribosomes are there, they are also stained blue in cytoplasm. It is suggestive of a rapid turnover of RBCs. So in which conditions it happens? Rapid condition might be hemolysis. In some settings Even marrow disorders also, means myeloproliferative disorders, they can be seen. So basophilic stippling, Hubble-Joly bodies, nuclei, polychromatophilia, means varying forms of chromatic, means ribosomes in cytoplasm impart slight bluish color, whereas it is slightly red in usual RBCs. So various colors, blue, red colors, all these things are suggestive of rapid turnover of erythroid mass. Okay, got the point? We will go to next slide. That is again about RBCs. Because of biconcavity, that disc, the central pallor is seen. On other hand, if it is not concave, it assumes a shape of sphere, then there won't be any central pallor. It is known as spherocyte. So these spherocytes are classically seen in hereditary spherocyte. These spherocytes are classically, as per textbook, are known in the setting of hereditary spherocytosis and also seen in hemolytic pictures, means lysis of RBCs, in clostridial sepsis, kind of those things. On other hand, if you see these terms, most of the terms, schisto, echino, ecantho, ellipto, means related to shapes. Most of them you come across in our parasitology. Schistosomiasis, Echinococcus granulosus, Acanthamoeba, elliptical, all these things. That means varying sizes and forms are usually, they have been described with some specific entities, but nowadays it is known that majority of clinical conditions like iron deficiency anemia or myeloproliferative disorders or inflammation, they can lead to all these kinds of pictures. So these are all of historical interest. Just for completion's sake, I have mentioned, we do not dwell upon this much. Things that we see on peripheral mirror, agglutination of RBCs, means they are held together like this. RBCs usually are negatively charged on surface. That is known as zeta potential, ZDTA. So that means they repel each other, just like India and Pakistan. But in the setting of increased proteins like plasma proteins, which are positively charged, say in this analogy we can take example of USA, where President of USA comes and force us to shake hands with those of Pakistani guys, then they will be together, means touching each other, agglutination in the setting of positive charge, because this zeta potential is lost. This is nothing but agglutination. So in the setting of agglutination, you have to suspect increased plasma proteins like multiple myeloma, or even you can say monoclonal gammopathies, kind of those things. Similar mechanism, pathophysiology, accounts for Rouleaux formation. Rouleaux formation means agglutination of RBCs, just like stacking upon each other like a coin. Rouleaux formation, which leads to increased ESR. Increased Rouleaux formation leads to increased ESR. So in the setting of excess proteins in the blood, or plasma proteins, or fibrinogen, say fibrinogen. Remember, this is a non-specific marker, ESR. It suggests of any kind of inflammation or paraproteinemias. Especially in the multiple myeloma, ESR can be more than 100 because of same mechanism. This positively charged myeloma chains can lead to agglutination of RBCs. Got the point? So they are seen like agglutination, Rouleaux formation. Look for inflammatory changes and also malignancies as per the patient condition. In this way, you can translate this knowledge of peripheral smear in your clinical practice. Otherwise, just it is going through report and forgetting at the end of the day. Please be careful, especially looking for these changes on peripheral smear in elderly patients. We will move on to next slide. WBCs are little bit bigger than our RBCs, especially polymorphonuclear leukocytes, also known as neutrophils. Neutrophils. These are the most common, or you can say abundant WBC, that is white blood cells in our blood or peripheral smear. Most of these neutrophils have got either 2 lobes or up to 5 lobes. If the WBCs have got lobes more than 5, it is known as hypersegmented, means excessive segment more than 5, which is commonly seen in B12 deficiencies. Why? Because there is a block in the synthesis of this nuclear material, so there will be inefficient division of nucleus, means more number of lobes will be present. This hypersegmentation in B12 or folate deficiency happens because there is block in thymidine synthesis. That is one of the basis for our DNA synthesis. So there won't be any further maturation of nucleus. On other hand, there will be continuous enlargement of cytoplasm. That's why it is known as megaloblastic picture, because those proteins were unaffected, and also those proteins which lead to pinching of this nucleus, they will also act. They lead to nicking of these WBC nuclei, actually which are supposed to undergo mitosis. That means essentially it is a mitosis block. Mitosis block. So because of the mitosis block, cell is enlarged, but nucleus won't divide. On the other hand, because of this nicking enzymes, lobulations do increase. On the other hand, sometimes you may see this report of band forms. Band forms are immature forms of neutrophils, prematurely released because of the stimulus, might be infection. So instead of 2, one nucleus will be shaped like this. Still they are not divided into lobes. So U-shaped nucleus represents immature form of neutrophil. So in states of inflammation, infection, you come across many changes like this. Next one is about the toxic triad that all we had discussed. You know, neutrophils has got 2 types of granules. Most common are primary granules, which are also known as azurophilic granules. These are primary granules because they are also seen in lymphocytes and other cells like monocytes. Whereas secondary granules are specific. Specific means specific to neutrophils, that we are not going to discuss secondary granules here. What matters is primary granules because of their content. What that contains? Our myeloperoxidase. This myeloperoxidase is one of the enzymes which is responsible for production of free radicals, which can lead to intracytoplasmic destruction of bacteria or other microorganisms. So in the setting of inflammation, infection, these primary granules, they become coarse and larger, and they release myeloperoxidase and also other enzymes. They contain lot of things, lysozyme, all kind of those things. I am not mentioning because it will go over our head. On other hand, just for completion sake I am telling, secondary or specific granules contains lactoferrin, which binds iron so that iron won't be available to microorganisms. In that way, also they will be helpful in receptor cycling. So, to summarize, primary granules are responsible for intracytoplasmic destruction of microorganisms, whereas specific granules are necessary for action extracellularly. One is catching iron away from the other microorganisms, and also helping in attachment to endothelial cells and release of proteolytic enzymes like collagenase. Collagenase is present in specific granules, okay, and other things are Döhle bodies. These are also nothing but accumulation of rough endoplasmic reticulum that already I have told. In the presence of infection and inflammation, there will be rapid proliferation of neutrophils. So, those immature neutrophils containing this rough endoplasmic reticulum will be released into circulation, and they will be seen as these entity, Döhle bodies. So, rough endoplasmic reticulum is the pathogenesis of appearance of Döhle bodies. Third one is because of appearance of phagosomes within the neutrophils. These phagosomes they internalize, means they catch the microorganisms and destroy these and destroy them within their organelles, that is phagosomes. On staining, they appear as vacuoles. So, cytoplasmic vacuoles are nothing but accumulation of phagosomes which are responsible for degradation of microbial products. So, these three toxic granules, coarse granules, Döhle bodies, cytoplasmic vacuoles along with shift to left is suggestive of sepsis. This you can assess with the help of peripheral smear, especially if you have got a good pathologist. So, in this way, peripheral smear helps you in delineating, means segregating the patient condition into, okay, stable, can be managed on outpatient basis, or has to be hospitalized. That's why understanding of every slide in this presentation is important as far as our clinical practice is concerned, not only for MBBS graduates. Okay? You know one entity known as Chédiak-Higashi Syndrome. Actually, it is a lysosomal disorder where these lysosomes, they traffic along microtubules. So, the genetic defect leads to lysosomal dysfunction. Of course, these primary granules are nothing but essentially a part of lysosomes. So, in such settings where the patient has got various other features like immunodeficiencies, albinism, neurological manifestations, the cardinal feature that is seen in WBCs, because of improper troughing of these primary granules, they fuse with each other, leading to giant coarse granules. Over a period of time, this condition can evolve, or you can say degenerate into lymphohistiophagocitosis, a permanent disease. Of course, this will be not in this context of presentation, so I limit myself here to primary granules. Out of theoretical interest, I am saying Chédiak-Higashi syndrome. One of the clues as far as peripheral smear is concerned is presence of large coarse primary granules because they are prematurely fused. Chédiak is a Cuban physician, whereas Higashi was a Japanese pediatrician. They independently published this condition way back in 1950s. That is historical interest. So, that's about these primary granules. Okay, we will move on to next slide. So far we have reached mid stage of our peripheral smear. Smallest cell is platelet. It is 2 microns. Now we have reached a stage of cells more than that one, because neutrophils, they are of 12 microns. Here eosinophils is little bit larger than this neutrophil. Okay. Eosinophil characteristically contain 2 lobes, means it is a bilobed cell. Eosinophilic cytoplasm, important in allergy, autoimmune conditions, kind of those things. Of course, I am not going to discuss much about eosinophils because we had discussed earlier in setting of allergy, mast cell biology. So I limit myself to those conditions where there might be increase in eosinophils, like eosinophilia, especially relevant to parasites in our country. What are they? Helminths. Second one is tropical pulmonary eosinophilia, filaria, kind of those things. Usually on peripheral smear, for every 30 neutrophils, one eosinophil is seen with a characteristic bilobed appearance. Though not relevant to our topic, one thing I would like to tell about eosinophils is that their eosinophilia. Eosinophilia means increase in eosinophil count. Usually it is taken as more than 400 or 500 per microliter or cubic millimeter. Absolute eosinophil count, AEC. So you can remember like this. Any value of more than 500 will denote eosinophilia, absolute eosinophil count. Especially when it is more than 5000, suspect malignancy, like eosinophilic leukemias. Between 500 to 5000, you can find out various etiology of eosinophilia, not only Helminths, but also collagen vascular diseases, leukemoid reactions, other inflammatory conditions, kind of those things. Remember, for eosinophils, because eosinophils are driven, as we had discussed earlier, mainly by interleukin 5. This eosinophil is directed towards multicellular organisms. That's why in biology, eosinophils have an important role as far as bigger organisms are concerned, like our helminths, nematohelminths, but not unicellular organisms like Plasmodium, Giardia, because they are relegated to neutrophils. So the basic, you can say, sweepers are neutrophils, whereas higher forms sitting in that hierarchy are eosinophils. Got the point? Here we are discussing peripheral smear, not counts. Counts are seen on our cell counters, means automated machine. Basophils are even lesser number compared to eosinophils. Compared to eosinophilic cytoplasm, basophils name itself contains basophilic cytoplasm. Most often if you see increase in basophils on peripheral smear, you have to suspect myeloid malignancies, especially chronic myeloid leukemia. This interpretation you have to keep in mind. Increase the number of basophils, if at all you find, it might be the marker of CML, chronic myeloid leukemia. Increased basophils, basophilia. Though of course CML can increase all forms of granulocytes. Absolute increase in number of basophils is highly suggestive of CML. CML is because of one very versatile chromosome translocation, T9 to 22. What happens is that the unfortunate normally functioning BCR gene on chromosome 22, which has got its own cytoskeletal regulation, all these functions, which is naively there regulating all these things, functioning through its serine 309 kinase pathway. This tyrosine kinase from chromosome 9, it comes in contact with these things. This tyrosine kinase kicks out this function of serine 309 kinase, and in this translocation, as it provides a place for this tyrosine kinase, it dimerizes. Two tyrosine kinase dimerize and irreversibly stick to this BCR. So in this setting, tyrosine kinase is expressed automatically, means independent of any gene regulation, especially in this dimerized form, leading to unregulated proliferation of all granulocytes, neutrophils, eosinophils and basophils. Here the practical implication of therapy of this CML. 2 decades ago there was not effective treatment for this condition, but with advent of that classical imatinib mesylate, which sits at this ATP binding domain of these things, tyrosine kinase, it blocks this interaction of BCR with the tyrosine kinase. So this slide represents theoretical implications to practical considerations. So in such settings where you see excess of basophils, CML, you do not worry. Refer to hematologist or oncologist. Okay. Let's move on to next slide. In hierarchy comes the lymphocytes, which are in bigger in size. There are 2 types of lymphocytes, small lymphocytes and large lymphocytes. Normally, predominantly are small lymphocytes. But in the setting of infection, inflammations, cells do enlarge, especially cytoplasm. The dense nucleus of small lymphocyte becomes lesser and lesser condensed. So on peripheral smear, if you see this phrase reactive lymphocytosis, it means transformation of small lymphocytes to large lymphocytes. Reactive to what? Infection, inflammation, other insults. Okay. On other hand, if you see this one, smudge cells, you should think of oncologist immediately. In this condition, CLL, chronic lymphocytic leukemia, with excessive proliferation of these lymphocytes, where sometimes there won't be any time for maturation of these cells lyse, only nuclei do remain. Membranes of lysed cells, they stick to each other, creating a smudge picture. This is known as smudge cell. So if you see this term smudge cell, think of chronic lymphocytic leukemia. Got the point? There are various other interesting features of lymphocytes, but remember, we are not hematologists. We are learning basics of peripheral smear, how to interpret and translate in our clinical practice. That will be fruitful for patients and also for us. So coming to final section of interpretation of peripheral smear, I came across various sizes of the cells. First one was platelet. If you remember, it was 2 microns, 1 to 2 microns. Next, I mentioned size of neutrophil, it is around 12 microns. Now comes the biggest cell, that is monocyte, which transforms into macrophage upon leaving this blood circulation. This is the largest cell in our blood, around 20 to 20 microns in size. You can say 20 microns. So 2, you can remember like this. Monocytes are also one of the rare cells that are seen, and previously we have discussed about monocytes, their biology, function, kind of those things. Monocytes are very peculiar cells. They ingest similarly peculiar organisms like Ehrlichia, but not anaplasma. Remember, Ehrlichia only. Histoplasma, and common which encounter in states of Bihar, kind of those things, Leishmania. In such intracellular infections, it plays very important role. especially morula formation in the setting of Ehrlichia. Okay. And another condition where we encounter increased number of monocytes is acute monocytic or myelomonocytic leukemia. Acute myelomonocytic leukemia. Another setting where we see some changes in monocytes are histophagocytosis. Histophagocytosis, where we can see intracellular inclusions of monocytes containing RBCs, neutrophils or other debris. In few settings, we examine material from the Buffy coat. Buffy coat is nothing but if you make that blood sample in a test tube, keeping it there for 1 hour, usually this test tube contains one anticoagulant. Topmost layer is plasma. Below that lies very simple WBCs. Bottommost are RBCs. This is about Buffy coat. Usually centrifuged blood is left like that in a test tube for 1 hour, it will form. Though it is not related to our topic, it gives comprehensiveness. So after 1 hour, if you see this test tube, topmost layer is nothing but water, that is plasma. And actually this Buffy coat contains, or you can say this Buffy coat constitutes less than 1% of total volume. But here major cellular elements lie. So what are they? Platelets, just below that lymphocytes, and below that denser ones like our granulocytes, like neutrophils, kind of those things. And down bottom we have got RBCs. So why Buffy coat is useful in some settings? Because they contain so many cells with the nuclei, they are helpful for DNA extraction of these cells, for cytogenetics, and also it is important for evaluation of few parasites, especially they can concentrate here like our Plasmodium. And also in the setting of severe cytopenias, means where on peripheral smear we can't see these WBCs, in such settings we can extract this Buffy coat so that we can analyze this morphology of these cells. And also, as we discussed earlier about DNA analysis. So for morphology, for DNA extraction and evaluation of some parasites, Buffy coat is quite useful. Hence this Buffy coat examination is quite helpful, not only in cytopenias but also in detecting some parasites, like as I discussed, Plasmodium, other protozoan species like Trypanosoma, Leishmania, Microfilaria, detection of these organisms, because this is the cellular element of our blood in addition to morphology. Hope you like this topic, especially application of our theoretical knowledge that is translating to our practice. It is not just for passing exams, it is helpful for continuation of our learning experience, which is applicable in day-to-day practice. Hope you all find this topic useful irrespective of your practice, whether you are MBBS student or a practicing clinician. If you are really liking this, what I presented, you can subscribe our YouTube channel, that is the MBBS Blueprint. And also please share with your colleagues so that it will be useful. By transmitting this knowledge, our overall performance would increase, because learning is always two-way process. Second account that you can follow is at Instagram, that is also in the name of the MBBS Blueprint. You can like that and also follow for day-to-day postings and also any recent updates on our medical literature. Thank you very much.